Hey, it's Dr. Suchard again with another clinical toxicology video for health science students. The topic this time is NSAIDs, non-steroidal anti-inflammatory drugs. But to be fair, we're going to be focusing mostly on ibuprofen. And this content corresponds to Chapter 35 in Goldfrank's Toxicologic Emergencies. The learning objectives are that after you finish studying the related material, you should be able to explain why we're focusing so much on ibuprofen and to describe the expected clinical effects in acute ibuprofen toxicity and how they relate to the ingested dose. And some good news, this is probably going to be one of the shortest topic videos in this clinical toxicology course. As you know, many different NSAIDs exist, and they all share a common mechanism of action. So it's expected, and has been demonstrated, that adverse effects and toxicities should be similar across this class. Also, most of the available literature regarding NSAID toxicity from acute overdose relates to ibuprofen, almost definitely because it's the NSAID that is most widely available over the counter. There are a couple of very popular brands of OTC ibuprofen that most of us have taken. So if the meds are widely available without a prescription, it makes sense that there are more opportunities for people to interact with and overdose on ibuprofen compared to the other NSAIDs, and generating most of the acute toxicity data available. We've already discussed that analgesics comprise a major source of drug exposures reported to poison control centers. And ibuprofen is involved in nearly 30% of these exposures, so we should probably know something about what's expected from ibuprofen overdose. And we're going to be differentiating acute toxicity and overdose from routine adverse effects. Of course, we know that therapeutic NSAID use causes a substantial burden of adverse effects, which are predictable based on their mechanism of action inhibiting prostaglandin synthesis. Prostaglandins are necessary for GI mucosal protection and in maintaining kidney and platelet function, for example. These are important topics in the grand scheme of medicine, but we're focusing today on acute toxicity. Fortunately, the typical clinical course with an acute NSAID overdose is benign. I'm much more concerned about a typical patient who ingests aspirin or acetaminophen than I am about NSAIDs. However, massive ingestions can occur in motivated overdose patients because of the easy availability of the drug and how it can be packaged in bottles containing hundreds of pills. The bottle shown here contains 500 tablets of 200 milligrams each, totaling 100 grams of ibuprofen. Or if you were feeling really ambitious, you could get a bottle with 1,000 tablets instead. There have been enough ibuprofen exposures that it's possible to predict the expected toxicity related to the dose ingested. If the dose is less than 100 milligrams per kilogram, pretty much nothing is expected. If you called a poison control center about a non-self-harm exposure to less than 100 milligrams per kilogram, they'd probably just observe the patient at home. For a theoretic adult weighing 70 kilograms, that would be an exposure of up to 35 tablets, or 7 grams. And a very large proportion of even intentional ingestions are to fewer pills than that, so most exposures are quite benign. In the range of up to 300 milligrams per kilogram, there can be mild GI and CNS effects. And when the ingestion is above 300 or 400 milligrams per kilogram, that's the range where we can see some serious ibuprofen toxicity, which includes metabolic acidosis, altered mental status, acute kidney injury, and cardiovascular collapse. But to get in that range requires ingestion of a very large number of 200 milligram tablets. Now that's possible with a Costco jug of pills, but at least it's rare. During my fellowship training, I admitted 2 patients who had significant ibuprofen toxicity that I can remember. They had very mild CNS depression, moderate metabolic acidosis, and presented with increased serum creatinine levels reflecting some renal injury. But all of these abnormalities had recovered completely by the next morning. While I was searching the internet for graphics to use in this presentation, I came across this question on Quora asking how many 200 milligram ibuprofen pills it would take to need to be hospitalized but would not kill. Nearly every person answering instead referred the inquirer to mental health resources, which was empathetic and kind, but I'm not sure that they ever got the answer they wanted. I hope that anonymous person is watching this video because the best answer you're going to get is right here on this slide. I wanted to end with this observation. The toxidrome of altered mental status with a severe metabolic acidosis may occur with any massive overdose of common over-the-counter analgesics. We've just seen that it can occur with a massive ibuprofen ingestion, although it's still true that the great majority of NSAID ingestions are benign. Altered mental status and metabolic acidosis are expected findings in a typical severe aspirin overdose. And that same toxidrome can occur, as discussed in another video, with massive acetaminophen overdose too. And it's not rare at all for patients or witnesses to confuse aspirin with acetaminophen or ibuprofen and to give a history that they took one, but it was actually a different medication. If I was suspecting exposure to any over-the-counter analgesic, I'd order serum salicylate and acetaminophen levels to help confirm or to correct the history. Well, that's it for ibuprofen and all the other NSAIDs. I'll be seeing you around.